Well, good morning, good evening, wherever you are. I warmly welcome you to this International Symposium on Multigenerational Data Linkage, wherever you are in the world. My name is Merran Smith, and I'm the facilitator for today's event. I'm based at the University of Western Australia in Perth, and I'd like to acknowledge the traditional custodians of the land that I'm speaking to you from, the Wadjak people of the Noongar Nation. I also acknowledge the traditional custodians of all the lands that we're meeting on today and pay my respects to elders past and present. First, some housekeeping. If you have any questions for today's speakers, please type them in the Q&A box at any time during the presentations. We'll answer as many questions as possible after each set of presentations. This webinar is being recorded. We'll email you the link as soon as it's available on the PHRN YouTube channel. So our first session today covers multi-generational linked data and their uses. I'm delighted to welcome Professor Lisa Lix and Dr. Amani Hamad from the Rady Faculty of Health Sciences at the University of Manitoba in Winnipeg as our first speakers. So over to you, Lisa and Amani.
Thanks very much, Merran. And I'm just checking that my volume is all right. Okay. Well, we're delighted to represent the University of Manitoba in Manitoba, Canada, and participate in this international symposium on multi-generational data linkage. This first session looks at the characteristics of multi-generational linked data and the uses that have been made of these data in multiple sites around the world. At the outset, I would like to acknowledge that the University of Manitoba is located on treaty lands of the Anishinaabe, Cree, Oji-Cree, Dakota, and Dene peoples, and also on the homeland of the Métis Nation. The University of Manitoba has been committed to moving forward with Indigenous communities in Manitoba as well as across Canada. And one way that we have done that is through our National Center for Truth and Reconciliation. Our focus in this session is to introduce the terminology and provide a high-level overview of centers that conduct multi-generational research. Now, we chose the title multi-generational in recognition of, while there may be sites that use linked data, we're doing parent and offspring studies increasingly with volumes of data and long periods of time over which linked data are collected. It's possible to now begin looking not only at parents and offspring, but also grandparents, and to connect in siblings and cousins and so forth. This provides a rich opportunity to answer a wide variety of research questions about both multi-generational and intergenerational effects. Our focus in this session is looking at where the opportunities lie for building information around family relationships from routinely collected data, and then combining that with objectively measured health history information, and in some cases, non-health information for entire populations. This provides an extremely rich environment for doing population-based multi-generational studies. This has been done, as Dr. Hamad will tell you in a few moments, at a few sites internationally, but there's much broader interest in that. One of the studies that we have conducted in Manitoba is displayed on your screen here. And while it certainly provided evidence of an association of parental history with offspring outcomes, what's also unique and I think very important about this area of research is the team that's involved. This type of research benefits substantially from epidemiologists, clinicians, data analysts, and also biostatisticians. And also at the outset, I'd like to emphasize that the interest in this area has arisen from the recognition of precision medicine, that emerging approach that recognizes that disease treatment and prevention that takes into account individual variability in genetics and in the environment and lifestyle is really a motivator. Now, while there has been linkage of large administrative databases to some genomics data, there are challenges with that area of research and recognition that the linkage of family members to construct family histories has a number of advantages in terms of being able to potentially tease apart genetic and environmental effects, and to be useful in a variety of contexts, including risk assessment and the risk of diseases and potentially for preventive efforts. Now, while family health histories have traditionally been collected using self-report information, the ability of record linkage to ensure that we have objectively measured information through that family relationship linked to administrative data that contains diagnostic information rapidly expands our ability to do a variety of multi-generational studies. This particular article highlights a number of these features, and while it emphasizes the need to do this throughout the life course, that could be challenging if we're relying on self-report information only. So that ability to have long periods of time over which we link family information about relationships with objectively measured health histories is really advantageous on a variety of fronts. All right, so with that, I'm going to turn the mic over to Dr. Amani Hamad, who will continue on with introducing this area to you.
Thank you, Lisa, and thank you all for your interest in this symposium. So for the next part of this session, I'll describe findings from a recently published paper that we worked on, where we did an international scan on sites that have family linkages using routinely collected data, so at the population level, and that can be linked to health data. And this work was led by one of Lisa's PhD candidates, Naomi. It should be available soon online in the International Journal Population Data Sciences. So I'll provide you with an overview of our findings. Where do we have such data? How do they form family linkages? What are the available data years? What types of data can be linked, health and non-health data for research purposes? And I'll also provide some examples of research using these data. All right, so in this map, you can see the areas or the sites that have such linkages. We found that there aren't many jurisdictions that have data across the generations at the population level. We have 6 sites, 3 European sites, Denmark, Norway, and Sweden, and 3 non-European sites, which are the province of Manitoba in Canada, Western Australia, and Taiwan. With that being said, there are some other sites in the world with multi-generational registries or surveys. The Framingham and Hunt studies are common examples. And in the next session, we will talk about an example from New Zealand. But for this particular session, I'm limiting the discussion to linkages at the population level from routinely collected data. So in these sites, we identified 3 sources for constructing the family linkages. And one source, the first one is population registries. This is the case in the European sites. So those registries are collected for administrative purposes. They contain information on familiar relationships using unique identification numbers, like the CPR numbers, for example, in Denmark. So each individual's record within these registries will have their own number and their parent's number, and that's how the familial linkages are formed. In these sites, the registration with the population registry is required by law, so that ensures about 100% coverage of all the residents of these countries. The second source is health insurance registries, and those contain information on individuals who are eligible to receive healthcare coverage. And examples are Manitoba and Taiwan. They both have universal and publicly funded healthcare systems. So health insurance registration is required for them to receive this free health coverage. And that means about 100%, virtually all the population is included in these registries. And just like the European sites, the family linkage is constructed using health numbers. In Manitoba, for example, we have the family registration number, which is assigned to the head of the household, their spouse, and their dependent children. The third source of family linkages, an example is Western Australia, where multiple sources are linked and cross-referenced to identify family relationships. For example, birth, marriage, and death registries. The coverage in Western Australia is slightly lower. There are about 94% of the population who have familial links in these databases. And the type of family relationships also vary depending on the site. For example, it can be legal. This is the case in Denmark, Norway, and Manitoba. So linkages might also include stepchildren or adopted children. And we need to keep this in mind, because if we're interested in studying the genetic influence of diseases, then we have a challenge here, because we don't only have biological relationships, but a mix of biological and non-biological relationships. In Taiwan and Western Australia, they have biological relationships. For example, in Taiwan, family members have to be blood related, as determined by birth certificates, for example, for them to be considered family. In Sweden, they have both. There are biological and adoptive relationships. So this is an example of a good site to do family studies that can tease apart environmental versus genetic etiology of diseases. And here's a timeline for when the collection of familial relationship data began in each of these sites. The red arrows indicate the start of data temporal coverage. So that's the time when, for example, those identification numbers were introduced. And the blue arrows indicate that they had retrospectively other sources of data where they got familiar relationships from. So for example, in Sweden, the family information with the registration number was implemented in 1947, but they had supplemental data that go back to 1932. In Norway, the national identity number was introduced in 1964, but they have multiple additional data sources. So they have information about familial linkages on individuals born as early as 1900. Denmark, the civil registration system started in 1968, and they have data back to 1960. In Manitoba, we started in 1970. Western Australia in 1974. And Taiwan has the most limited temporal coverage, with data going back only to 1995. So given those data years, we can predict how many generations are identifiable in these databases. So maybe 3 to 4 generations in all of these jurisdictions except for Taiwan. And it's likely that only 2 generations can be identified in Taiwan data. And those multi-generational data in the different jurisdictions can be linked to numerous health databases. So all of the sites that I mentioned have linkages to hospital and physician visit records, and most of them also have linkages to drug dispensation databases. Some additionally have linkages to, for example, cancer registries or ER visits, among many others. So Sweden has over 100 linkable healthcare registers. In Manitoba, we have over 50 health datasets that can be linked to the multi-generational data. Some sites also have linkages to social datasets, educational data, or justice data, and this is the case in Manitoba as well. So multi-generational linkage provides a source for many research opportunities, because it allows us to study the biological factors, the shared environment, and heritability on chronic disease risk at the population level. So I'm providing here some examples of potential opportunities and research applications from each of these sites. And one common research area uses family members as a comparison group, for example, in sibling or twin studies. So when we compare the risk of health or non-health outcomes between siblings, this inherently accounts for genetic and shared environmental factors or household exposures, and reduces the risk of unmeasured compounding. So I have here 2 examples on using family members as comparison groups. In the first one, this study was conducted in Sweden, and it assessed the association of PTSD and educational achievements using a sibling design. And this is another study in Manitoba, which looked at mortality among mothers whose children were taken into care by Child Protective Services, and also used a discordant sibling design. We can also examine risk or predictive factors within families, so the impact of family health history on current health status. An example is this study that used Danish data to test the association between parental rheumatoid arthritis and the risk of autism in offspring. Another example in Manitoba is a recent project we published on the association between parental diabetes and offspring osteoporotic fractures. And there's another ongoing project that Lisa will describe in the next session it looks into using complete family health histories to predict the risk of chronic health conditions in the offspring. We can study the intergenerational transmission of diseases, so the influence of family history on disease risk. For example, multigenerational data here in Norway were used to examine the risk of ADHD of offspring whose parents had ADHD. And this example is another one from a research group in Manitoba, which examined the intergenerational transmission of osteoporotic fractures. Taiwan data in this example was used to study the association between having any first-degree relative with schizophrenia on individuals' risk of having psychiatric disorders. We can study the effects of exposures across the generations. So we can study, for example, the effects of drug exposures, smoking, or any other event in the parents and the effects on the children. So for example, this Danish study looked at the association of prenatal acetaminophen exposure and autism risk. In this one, authors used the Western Australia data to quantify and characterize offspring whose parents had cancer during their lifetime. Or we can do it the other way around. So we can look at events in children and outcomes of parents. And this study in Manitoba is a good example. It looked at mental and physical outcomes in parents who had an offspring who died by suicide. And this is another example using the Swedish data, and it examined the association of antipsychotic drug exposure in offspring who has schizophrenia with parental health and work disability. One last opportunity, multigenerational linkages are also important in the field of maternal and child health because they allow the linkage of mothers and children, and then we can use any of the applications that I just mentioned. And there are several pieces of work that looked at prenatal medication exposure and the risk of neurodevelopmental disorders, so ADHD or autism. Like those two examples, one of them looked at prenatal antibiotic exposure and one antidepressant exposure during pregnancy with the risk of neurodevelopmental disorders. There are other pieces that looked at maternal mental health and social outcomes after custody. And in this example, they looked at breastfeeding initiation and association with diabetes risk in offspring. And those are among many other examples in the field of maternal and child health. So there are many applications and research opportunities for the multigenerational linkage, not only in health, but also in non-health research. And those are just some examples. So a few points on the strengths of these data, because these multigenerational data are population-based. We have large cohorts that are representative of the entire population. We have data that span decades. So this allows creating complete family health histories across multiple generations. We can link health and non-health data. This allows us to capture a large number of variables and allows us to do research beyond health outcomes. And because we are looking at physician visits, hospitalization, for example, so we have only diagnosed conditions, so we can measure objective outcomes. And there's less risk of recall bias that's encountered using self-reported data. But there is an important challenge to consider, which is misclassification or incomplete linkages. Because as I mentioned, in some areas, parental linkages are based on legal status. They do not necessarily capture biological relationships. And in this case, additional sources, for example, the adoption registries or birth registries, they can be used to obtain biological information. However, if adoption is an issue, the proportion of adopted children at birth is small. We explored this in Manitoba and we found out that less than 0.5% are adopted at birth. So this shouldn't have a significant effect at the population level. The second source of misclassification is that unlike maternal relationships, which are straightforward to determine, paternal relationships to determine, there are some assumptions to make. So the male spouse, for example, is assumed to be the father. And this results in potential misclassification of paternal linkage. And it also makes it harder to differentiate between half and full siblings. And the third source is that relationships are not consistent over time. The linkage is variable over time due to methodology changes or family structure changes. And an example here in Manitoba, this figure describes the multigenerational linkages On the x-axis, we have birth year. On the y-axis, we have the proportion of linkages to parents and grandparents. And throughout the years, you can see that maternal linkages in solid line are consistent. It's close to 100%. But paternal linkages are declining over time. We started with about 87% for those born in 74, up to only about 38% in those born in 2018. And similarly, linkages to grandparents in yellow and blue, they improved slightly, but then they declined again. So we need to take this in consideration when we plan a study. For example, if we want to maximize paternal linkages, then it makes sense to develop a cohort of those born in the earliest years. I'll finish up with a few thoughts on the future of multigenerational studies. There is a potential, as Lisa mentioned, for expanding linkages to genomic data and biobanks. This, of course, will require a process to overcome the ethical and logistic concerns. The second piece is to identify and validate alternative sources to create family linkages. There have been studies that use emergency contacts, for example, residents, information from surveys, and those can offer a way to create familial linkages when we don't have such population-based data. A third piece is to develop methods to tease out environmental versus genetic effects. For example, looking at biological versus adoptive relationships. And there has been some work using these methodologies, but there is still an untapped potential to better use these data to understand disease etiology. And finally, there is a potential to create international multi-generational linkage network to facilitate collaborations, identify opportunities for multi-site studies, and advance multi-generational studies. I just want to acknowledge all the collaborators who worked with us on this paper and also other multi-generational studies. And thank you all for your attention. Merran, it's back to you.
Yeah, thanks very much, Amani. That was a wonderful presentation, and thanks to Lisa too. We have got some time for questions, and I note that the audience hasn't been very active in the Q&A space. So I do encourage you to come up with questions during the presentations. But I actually do have one question. And
there is one, Merran, there is one in the chat.
In the chat, okay.
From Jason.
Well, can you pick that one up, Lisa? Because
yes, I sure can, and sorry to interrupt there. And so it says, thanks very much for the presentation. Amani, can you explain why the paternal linkage proportion is changing over time and what bias might be operating amongst the current paternal linkages?
Yes, good question. We get this question very often. So the way fathers are identified in the Manitoba data is dependent on their relationship, their marital status, or their relationship with the woman, with the spouse, to be reported to Manitoba Health. And recently, with the increase in the number of non-traditional relationships, and also couples are not that eager to report their relationships to Manitoba Health, we've been not able to capture as many paternal relationships as we want. So that's the main reason in Manitoba. It might apply to other jurisdictions as well, but at least for us, that's the reason, because we have to make assumptions. The partner, the male partner of the registrant, is assumed to be the father, and in many cases, they don't share the same number because their relationship is not reported. I don't know if you have anything to add, Lisa?
No, thanks, Amani. That's very comprehensive.
Okay, thanks. And I just have a question about whether electronic medical records might have a role to play in multi-generational studies. So would they be a source or a potential source of family relations data?
There was a recent paper in the US that relied on emergency department records, and where they were not completely anonymized, but were able to identify name and address information and use that to actually build family structures. So this approach relies on data mining techniques and electronic medical records in order to be able to do that. Now it's dependent, Merran, on being able to have access to data that are not completely anonymized, which is not the case in every jurisdiction. but it does raise the prospect that as we have data mining methodologies and potentially increasing access to various kinds of data, that there are other approaches that we can use other than relying on information that comes from health insurance registration or legal relationships to do family linkages. Amani, would you like to add?
Yeah, I'm not sure if we're talking about the same study, but there is also another, I don't know if it's the same one, but there's the study in the US that used the emergency contacts from electronic medical records to form familiar relationships. So that's another source.
Okay, thank you. And we do have a question in the Q&A. So Russell, thanks for the first question, and a second's just come in as well. But with the first question, it's, could you talk a bit more about migration effects, especially for Manitoba, but also for the national registries in Scandinavia and elsewhere? Are you able to censor by determining when a person may have left, both in terms of parents, grandparent exposure and child exposure?
I can start and then I'll leave it to you, Lisa. So the Manitoba population is generally considered stable. There aren't a lot of moving out and of the province. But with that being said, we have in the registry a code that tells us why did the individual left the province. Where did they move to? Was it because of death, or did they actually migrate out of the province? So we have some details into why we censored the person. And that can be included in the research. I cannot talk specifically about the European sites. I don't know if you have anything to add, Lisa?
Yes, with linkage to an increasing number of data sources in sites around the world, such as in the Scandinavian countries. So linkage to the death records, for example, would enable to know why someone is lost to follow up. So with the increasing number of linkages to different kinds of data, then it is possible to ascertain why someone may have left.
Okay, thank you. And there's a second question from Alberto Netalaguirre. Have you tried to use a small subset to confirm the relationship that's assumed or found as a measure of potential misclassification?
Okay, I can start off with that. Yeah, so assuming that we had some reference standard database where we knew the relationships, how well do we identify them? That's not something that we've done in Manitoba. And in fact, when I look at studies internationally that use family relationships, there's been very little of this. Trying to identify a gold or a reference standard database would be the challenge with this. But it is an approach, particularly as we find that over time we're losing paternal relationships, and we're not able to link with fathers or the heads of household both heads of household, for example, that it's increasingly important for us to identify data sources that we might use to do validation. So thanks, Alberto, for that question.
And we've got another question from Jessia Berry. How do you examine increasing diagnoses over time due to increased awareness and changes? For example, ADHD when you're looking at parent-offspring transmissions. Would it be different for families born earlier in a cohort rather than later, or different for parent versus child as well?
Yeah. Well, I think we're going to address the issue of how we look at these objective health histories over time. Dr. Hamad is going to actually give a presentation on how we've done that in Manitoba. And so perhaps we'll just reserve that question. But absolutely, there are different diagnostic criteria being applied over time, particularly when we think about data that are going back more than 40 or 50 years in different sites. And so how might we address some of these challenges will be a topic that we'll explore in our time together today.